Good day. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to our Wednesday webinar series entitled The Medical and Public Considerations of COVID-19. Today's session is going to be on inflammatory response in children and adults. Next slide. I'd like to thank the following webinar series partners. Next slide. All these webinars are recorded and posted to the ACMT website within 48 hours. Information about these webinars can be found at the info@acmt.net if you have any questions. Next slide. At the end of the webinar, there will be a Q&A for the speakers. Please chat in your Q&A questions either into the Q&A function or into the chat box. You can do this either on the WebEx or for those of you following on YouTube or Facebook Live, you can do that as well. Next slide. At this point, I'd like to turn it over to my co-moderator, Dr. Ziad Kazi. Dr. Kazi is a board member of the American College of Medical Toxicology and president of the Middle Eastern North African Clinical Toxicology Association. Dr. Kazi will introduce our speakers for today's session. Thank you.
Thank you, Dr. Wax. It's my pleasure today to introduce our first speaker, Dr. James Schneider. This topic for today was actually based on recent attention in the media regarding the multi-inflammatory syndrome in children. I had heard about it, I've read about it on various media outlets and news outlets, and then enjoyed watching a webinar organized by the Centers for Disease Control and Prevention, referred to the COCA webinar, where Dr. Schneider and Dr. Marconi presented on this important topic. Realizing the importance of bringing those two topics together to you today, we were fortunate enough to getting them out of their busy schedule to talk to us. So we will start initially with Dr. James Schneider, who will discuss the multisystem inflammatory syndrome in children. Dr. Schneider is a chief of pediatric critical care medicine, as well as an associate professor of pediatrics at Cohen's Children's Medical Center in New Hyde Park, New York. He will be followed by another presentation by Dr. Marconi regarding the inflammatory response in adults and possible immune modulators. Dr. Schneider, the floor is yours.
Great. Thank you so much, Dr. Kazi, for the introduction, as well for the invitation from the whole society for being here to share our experience here at Cohen Children's with this newer syndrome that we're seeing is associated with COVID-19, that, as you said, is now termed the multisystem inflammatory syndrome in children. I do not have any conflicts of interest to report. I just want to give a little background. So we are the Children's Hospital for a 23 hospital health system here in New York, the Northwell Health System. And we're a large hospital with a 37-bed ICU that really covers the gamut of all of pediatric critical care. And we have seen quite a few of these children that I'd like to share. And I'm really going to speak on behalf of a whole group of individuals here at our hospital that have spent a lot of effort, just like many others out there, to try to gather this information and learn as much as we can and share it as a community so we can get a better handle on this. So I speak on their behalf as well. As we're all likely familiar with, there was a new recognition in March over from in the UK, where there were multiple pediatric institutions. They started noticing during the peak of their pandemic of COVID-19 that had multiple children presenting with this febrile inflammatory illness, and they all looked similar with fevers, with sore throat, with headaches. Many had rashes or conjunctivitis and gastrointestinal symptoms. All symptoms and signs that were consistent with what looks like either Kawasaki's disease or toxic shock syndrome. And in fact, many of these children required ICU level because they did or have dysfunction. And when looked more closely, it was clear that there was evidence of inflammation or inflammatory syndrome by evidence of elevations of ferritin, C-reactive protein, D-dimers. And interestingly, despite the fact that there was a high incidence of acute COVID infection in the region, these children were mostly negative for SARS-CoV-2 when looked at PCRs. So this seemed to be perhaps related to COVID-19, however, not due to an acute COVID-19 infection. So they reported to us as a medical community on April 27th, which really opened the floodgates for us when this top report here that we all saw of their case definition of what they were terming the pediatric multisystem inflammatory syndrome temporally associated with COVID-19. And then subsequently, there were a few early publications, both from the UK as well as Italy, which could describe more children with similar symptomatology. And around that time, we were already starting to see here in New York and in our institution, multiple children who were fitting this clinical presentation. And it definitely started raising the red flag that, hey, perhaps this was actually something that was becoming more common. And then the information got to the World Health Organization, the CDC, where they presented with us at least a preliminary case definition so that we could all be working under the same paradigm, so we could really start to understand a little bit more of what was happening. So here you see is the WHO's case definition, which really encompassed the entire pediatric age range of 0 to 19 with fever for at least 3 days. There needed to be evidence of organ involvement, whether it was the skin with rashes or the mucocutaneous findings, a cardiovascular system with hypertension or shock, or evidence of myocardial dysfunction, cardiolopathy, or acute gastrointestinal symptoms. There also needed to be evidence of inflammation with things such as elevation of the ESR, C-reactive protein, or procalcitonin. Further, of course, it was important to eliminate any other source of this inflammatory syndrome. So we looked for other microbial causes. And of course, to tie it to COVID-19, there need to be evidence of COVID-19 either by antigen or by serology, or just to have a contact with a likely or known case of COVID-19. CDC proposed around the same time a similar definition. They extended the age range to 21 years, and they also shortened the duration of fever to require to only a day. And at this point, the terminology was modified to the current terminology, which is now known as the multisystem inflammatory syndrome in children, or. So before I get to our specific institution's experience, I do want to share with you this kind of interesting numbers. For those who may not be familiar, this is from the VPS, or the Virtual Pediatric Services, which is a large, more than 200 hospital, North American hospital collaborative of quality data that gets inputted for all ICU patients, and it's pretty much the largest pediatric critical care quality database that's led to also not only allows for benchmarking for quality, but of course also has led to many, many publications that otherwise would not have been possible. And at the time of this COVID epidemic starting, then they opened up a separate specific repository for data related to COVID-19 specific illnesses in the pediatric ICUs. And you can see here, as of May 31st, there were 183 sites who have been contributing data on COVID infections or COVID illness, and there were 547 patients had been admitted thus far. But interestingly, if you go to the next page, after the MIS was identified as a COVID-related entity, then we've now been adding data specific to MIS, and of a little more than half of the patients, overall patients, so 291 patients in this cohort here, you could see in the red box that I've highlighted that about half, the dark blue of the circle, about half of all COVID-related infections in pediatric intensive care units have been made up of MIS-C patients. So clearly this syndrome is imposing a large burden to pediatric critical care in the U.S. Of recognition of this entity, we've been working, like many other institutions, to try to come up with a way of classifying these children, identifying these children, and then, of course, standardizing a treatment approach. So this here is our current identification and treatment algorithm. So in order to be classified as MIS, we see here that children need to have fever for at least 4 days and have some evidence of symptoms that go along with Kawasaki. So things like headache or irritability, conjunctivitis, cough, oral changes, gastrointestinal symptoms, or rashes or swollen hands and feet. And when children hit any of those triggers, then they get a further workup to look for evidence of inflammation and myocardial involvement. So we do things like a CBC and CMP, and this is mostly done in the emergency departments, frankly. CBC, CMP. We also look for evidence of inflammation specifically with C-reactive protein, procalcitonin, ferritin, D-dimer, fibrinogen. We look for evidence of myocardial involvement with B-type natriuretic peptide levels and troponins. We do look at the coagulation factors, as well as looking specifically for evidence of SARS-CoV-2 with either a nasal swab for PCR and blood for serology. And again, we want to rule out any other source of this inflammatory presentation, so we do blood cultures and respiratory viral panels. At that point, then we also classify children based on their presentation into 4 different clinical categories. Many children have been presenting with cardiogenic and or distributive shock. Many children present with all features of classic Kawasaki disease. Multiple patients presented with evidence of incomplete Kawasaki disease. And then there are those who don't fit any of the specific Kawasaki or shock criteria, yet they have evidence of ongoing fever and some evidence of inflammation, so they get put into what we call the observation or category 4 bucket. And if you look at here, this is our hospital's the epidemic curve of acute COVID-19. And overall, up to date, we've admitted over 100 children already to our children's hospital with COVID-related illness. And you see the black squares here represent the incidence of hospitalization for acute COVID infections with a peak of about 25 or so in one day. And then thankfully, we see it has been coming down. But then at about 4 or 5 weeks after the peak of acute COVID infections, when we start to see this significant rise in the incidence of MIS-C patients. And thankfully, I can report that if I were to continue this curve on, that we have that New York State, New York City Department of Health. What many have seen is that this tends to be an older age range compared to Kawasaki, for example. So our median age range is 8.2 years of age, with 64% of whom are male. We do see about 27% Black, 13% Asian, 13% white, and 21% Hispanic. And that's a fair representation of our general demographic that we do see here at this institution. I have a little more granular data on right now, currently 33 patients. We have more that obviously we're continuing to gather and collect more data to analyze. But in general, our patients have all been generally normal, healthy patients without any underlying comorbidities. We did see 39% of those who were obese. So perhaps there is some propensity towards obesity. We do know in the acute COVID infections in adults and even some in children now that obesity, hypertension, diabetes, those tend to be the high risk factors. But in this population of patients, the children are generally healthy patients with no predisposing factors. In fact, if you asked by history if they were either had evidence of acute SARS-CoV-2 infection or known contact with someone who was or suspected of having COVID-19, usually the answer is no. There is often no evidence or no recollection of any contact with COVID-19 prior to presenting with this syndrome. There were a few children who did have an underlying history of reactive airways disease. However, whether that has a factor, I guess we'll learn as most patients presented with a fever about 4 days. About 58% of the children had neurocognitive symptoms on presentation, things like irritability, lethargy, things of that nature. And we know obviously with Kawasaki, most of the kids are irritable when they do arrive. Interestingly, almost universally, the patients presented with gastrointestinal symptoms, all but one, which include either abdominal pain, vomiting, diarrhea. We definitely have seen gastrointestinal involvement with acute COVID, but even in patients reported with this syndrome, we know many children are presenting with GI symptoms, many of whom have even had surgical involvement and even laparotomies to look for surgical sources, but nothing has been identified. Only half of the children have had respiratory symptoms when they presented, and typically the children who have respiratory symptoms are not due to acute pulmonary disease. Rather, it's secondary to cardiovascular dysfunction. And I'll get a little more detailed related to that when we get to the therapies. Interestingly, and also alarmingly, 3/4 of the children who presented have presented in shock, which means they've either required multiple fluid boluses, but most have required either vasoactives, either inotropes or vasopressors. 64% of our children had met complete Kawasaki disease criteria, and of those who met complete Kawasaki disease, 3/4 of them also had shock, which is quite different than the typical Kawasaki population, where we know that only about 5% of children who have complete Kawasaki disease will ever present with the shock syndrome. Of the entire group of patients that we've seen so far, 61% have needed ICU admission. And what we have seen over time is that the children who presented earlier during this time period more commonly presented with shock and needing ICU. In fact, of the first 33 patients, 79% of them needed ICU care. But thankfully, what we've seen over the last probably week or two is that the majority of children are less severe and have been treated on the floors. Overall, the children have been staying in the hospital for an average of 4 days. When we look at all the labs that we've obtained on these children, it's quite interesting. Most have normal white blood cell counts. However, the vast majority, 80%, are lymphopenic on presentation. And we do know that we have seen that in the acute COVID-19 infections as well, both in children and in adults. Children presented often with a mild anemia. The platelet counts have been normal in our children. However, we have seen other reports of thrombocytopenia being common in these MIS-C patients. Remarkably, and again, going along with the inflammatory process, the C-reactive proteins have been significantly elevated. The dimers are elevated. Fibrinogen and ferritin have been quite elevated. Many of whom have had a mild coagulopathy on presentation with INR of 1.3, co-infection with bacterial infections. Commonly, we see a mild hyponatremia with a median of 133, mild elevations of the transaminases, and a mild decrease in albumin. So looking specifically at the evidence of SARS-CoV-2 in these children, of all those that were tested, 86% of whom had IgG positive. And at the time that I put these slides together, we don't have data on all the children yet because earlier on in the cohort, early on the time period, we didn't even have the capacity to test for antibodies at that time. So the children who were part of this cohort that was seen earlier during follow-up with infectious diseases and cardiology, that's when we will look for their serologies. Only 1/4 of the children had PCR positive for SARS-CoV-2 at the time of their presentation here. When we look at the combination of immune globulins and PCR, only 22% had both positive PCR and IgG, and the vast majority have had IgG positive, however, PCR negative. Again, speaking to the likely or the thought process of this being a post-infectious inflammatory syndrome. What other organs have been involved in these children? We have seen about 20% have some degree of hepatopathy, as I mentioned, very mild, with relatively mild elevations of the transaminases. However, we see a very high incidence of acute kidney injury in this population of children. And we know in the adult, particularly adult acute COVID population, that AKI was quite common and associated with worse outcomes. It is very common in this group of children as well. Related to respiratory support, half our children needed some type of respiratory support, mostly just supplemental oxygen. Few have required positive pressure ventilation. And again, as I mentioned earlier, that the respiratory support almost invariably was due to secondary to cardiovascular dysfunction rather than primary lung disease. 6 of our children have required intubations, and they remained on the ventilator for a median of 3 days. It's the cardiovascular involvement which is really profound in this group of children. We did see that about half of the children had coronary artery abnormalities. And just again, to put that in perspective, when we look at Kawasaki disease, typically without treatment, 23% of kids with Kawasaki's will develop coronary abnormalities, particularly enlargement and aneurysms. And after treatment, only about 3 or 4% will have aneurysms. So in this population, half of whom have had coronary artery abnormalities on presentation is quite shocking. About 15% of them have had z-scores greater than 2.5, which is classified as having aneurysm. And when we look at the myocardium itself, 58% have had some degree of myocardial dysfunction, or mild. I can share that, many of these children have already been followed up. Thankfully, all the myocardial dysfunction has mostly resolved, and even the coronaries on almost all of them resolved. And so these are the medications that we've been used, and we really our algorithm from the Kawasaki disease literature, and really taking the intensified strategy approach to treat these children. And so 100% of our kids have been treated with IVIG, a third of whom have required a second dose of intravenous immunoglobulin, and the indication for that was incomplete resolution of fevers after the first dose. There are pretty evidence that the use of steroids, particularly methylprednisolone, can help to decrease the incidence of coronary aneurysms. And so all the kids who end up in the intensive care unit, by definition, are high risk, and they all get steroids as well. We do have different dosing of them depending on the severity of illness. So anywhere from a pulse dose of 30 per kilo down to either 1 or 2 per kilo per dose twice a day. And they all get at least a 2-week taper as well, again, extrapolated from the KD literature. The majority of children received aspirin as well, again, part of the KD paradigm. A few children have received some type of biologic, either anakinra, tocilizumab, or infliximab. And then most patients, as again, we know from the acute COVID-19 data that and experience that there's a large propensity towards thrombophilia. And so for every one of our patients, we do consult with our hematologist, and based on multiple variables such as heart function, degree of inflammation based on D-dimer and CRPs, and trajectory, the patients often get some dosing of enoxaparin on top of the aspirin. Thankfully, I'm happy to report that we've had 0 mortalities in our population. The vast majority have already been discharged. And when they've been discharged, many of their cardiac function has at least improved significantly, either to complete. Some of my the reports I'm getting from my cardiology consults is that is seen in cardiology clinic a week or 2 later. So just to kind of almost summarize the difference that we've seen in the MIS-C group versus acute COVID-19, as we mentioned, most of our children have been previously healthy rather than having underlying comorbidities. We've seen a much larger age range, as low as 6 months up to 19 years. And in fact, we have seen reports of some older children or really younger adults in their 20s. But in our hospital, we only admit up to age 19, although now we are starting to accept children into their 20s if they're presenting with this syndrome. In acute COVID-19, we know most patients show up with some degree of pneumonia or primary lung infection. However, in our MIS-C patients, the obtained are normal, and if they require ventilatory or respiratory support, almost invariably it's secondary to cardiovascular compromise. We do know that basically every patient with MIS-C by definition has significant elevations of inflammatory markers, which is different than the acute COVID-19, which there are a subset of patients who do have significant elevations in what we call the cytokine storm. And then with this group of patients, most patients do not have any acute evidence of SARS-CoV-2 when we do nucleic acid amplifications, but almost all of them have evidence of IgG positive, again, indicating a prior infection. And then lastly, just to highlight the significant differences from Kawasaki's disease, is that this group of patients are significantly older than Kawasaki, our median age of 8 years, where Kawasaki typically in our institution is 2.5 years, which is the typical or so age range in general. We have a much higher proportion of children with this syndrome who are presenting with shock compared to Kawasaki. I mentioned is only at most about 5%. As a pediatric intensivist, I generally don't see too many Kawasaki patients, and we've seen the majority of these children, so it's quite surprising. The elevation of inflammatory markers has been more profound in this population compared to Kawasaki. And then again, also universally, virtually, these children have presented with gastrointestinal symptoms, which really has become one of the very important screening tools when children are presenting. At this time, first I thank everybody for their attention, for participation, and for the opportunity to present at this wonderful session.
Thank you so much, Dr. Schneider. This was a wonderful presentation, very informative. I know we have a lot of questions already that have popped in that I hope you will be able to stay with us till the end and take those questions then. Also, would like to participants to type your questions as the webinar is ongoing, and we will address as many as we can at the end. Dr. Schneider, it's really great to hear about this post-inflammatory, post-infectious inflammatory syndrome that you described. It emphasizes the importance of having our next speaker talk about the inflammatory response of COVID-19 in adults and the role of immunomodulators. Dr. Vincent Marconi is a professor in the Division of Infectious Diseases at Emory University School of Medicine, as well as at the Department of Global Health at Rawlings School of Public Health in Atlanta, Georgia. He's been involved in the clinical trials of some of these immunomodulators, and his perspective on the inflammatory response to COVID-19 and the therapies will be crucial after your presentation. Dr. Marconi, please go ahead.
Terrific. I also want to thank you, Dr. Kazi, as well as the organizer of the American College of Toxicology, for the opportunity to talk again with Dr. Schneider as well. This is great to meet back up with him again through this kind of venue. I think Dr. Schneider did a great job of really describing MISC, as well as drawing the parallels between it and COVID-19, as well as Kawasaki's disease. And I think what I would like to do here, as Dr. Kazi mentioned, is talk a little bit more in detail about the COVID-19 hyperinflammatory syndrome. Again, trying to draw some of the parallels that how they distinguish themselves from MISC, as well as what can we do about this? What are some of the therapies being explored specifically around settling the hyperinflammatory syndrome? I have consulted and received research funding from the various pharmaceutical companies listed here, but have no conflicts directly with what's being presented. So I thought I would start just patients I saw here in Atlanta with COVID-19. This was a 47-year-old, relatively healthy male who really had no significant past medical history and actually was not obese, might have been slightly overweight, but otherwise no hypertension, metabolic disease. And he presented relatively sick to the hospital, had a robust fever, cough, was already showing signs of dyspnea on presentation. And similar to as what was described with some of the MISC patients as well, had gastrointestinal involvement, which is not incredibly common, but we do see this in adults with COVID-19. And at the time of presentation already was requiring oxygen supplementation, and really within 3 days of admission was sent to the ICU with respiratory failure, was ventilated. Very quickly required high amounts of oxygen. You can see the FiO2 there, going up to 100% for several days, and high amounts of PEEP, especially in the first couple of days as well, which was weaned. Some of the injuries, even through the process, had some barotrauma from the high levels of PEEP, again, that were weaned, and may have contributed somewhat to the rest of his course. But the other complications he developed have also been very well characterized and described for patients with COVID-19, severe and critical COVID-19. And that included, in this instance, He developed AKI on the 6th day, acute kidney injury, and shock by the 7th. Also developed a DVT on the 10th day, and was also dealing with a bacterial pneumonia, which again could have been in part from the barotrauma that he had experienced early on in his mechanical ventilation. He did, thankfully, by about the 11th day, start to resolve his fever. And as you can see across the top of the figure, there's a number of elevated biomarkers that also tracked with the fever. As you can see, some decreases slowly over time in his C-reactive protein and also his D-dimer, which was markedly elevated upon presentation. He also had an elevated ESR, which did not resolve all the way through his ultimate recovery on day 23. So this is just meant to be kind of a cartoon or representative graphic of what we believe the various stages of COVID-19. Again, this is not taking into account the MISC, as Dr. Schneider mentioned, as a kind of later phenomenon, post-infectious immunologic phenomenon. This is really still within the throes of active viral replication for the vast majority of these patients in the respiratory tract, for sure. And so the way we have understood this disease to date is, in the beginning, there's significant amount of viral replication, again, in respiratory tract areas, as well as cardiovascular system and elsewhere throughout the body. And through this time is where you will see people having mild sort of constitutional symptoms, fever, and that sort of thing, without significant amounts of dyspnea for the vast majority of patients. Now, about 40% of these individuals will go on to have some degree of respiratory symptoms, and it doesn't necessarily have to be later on in the course. As you can see, the phase 2A of stage 2, which is the pulmonary phase, and that's where we will see shortness of breath. If people go on to progress with this, they can develop hypoxia, and there'll be abnormal chest imaging at this time. And biomarkers in terms of typically we will see elevations early on, those with much more significant elevations and very significant decreases in lymphocyte count, and especially CD4-CD8 ratio changes will be the ones that normally will be predicted to move on and progress through the rest of this spectrum. About 14% of patients will go on to have severe illness, and this is where you're progressing on into this greater inflammatory response phase. And then an even smaller percent of patients, about 5%, will go on to have critical illness. And this is where you have the hyperinflammatory phase, the stage 3, where patients will go on, as the one I presented, to have systemic inflammatory response syndrome or shock, multi-organ dysfunction, ARDS, cardiac failure, etc. And this is the And it's through this period where people have really tried in phase 2B and into the third stage to consider using anti-inflammatories, or even in some cases even earlier, depending on what's happening. And so why does this happen? I think it's first important to remind ourselves of how the virus actually causes disease. So as we all know, it enters through respiratory tract, primary entry point, and it binds to various endothelial and epithelial surfaces through the ACE2 receptor. And in that process of binding the ACE2 receptor, those receptors get internalized into the cells as they follow through with the endocytosis process. The virus is engulfed into the cell, and that loss of that ACE2 receptor actually causes an imbalance in the ratio of angiotensin 2 that you can see here kind of in the center of the figure, and angiotensin 1,7. And that imbalance is really critical because of the loss of this enzyme, this ACE2, that it upsets the normal homeostasis between reactive oxygen species. These are those things that can cause lots of harm, breaking up DNA and causing membrane disruptions, etc. And on the other hand, vasodilation, which obviously helps for blood flow through the eNOS pathway. And because of this imbalance, these reactive oxygen species then lead on to what is one of the most troubling aspects of this disease is the thrombotic pathway. And that's primarily microthrombotic, although we absolutely see, as in this patient I described, deep vein thromboses. The microthrombotic process is probably the most pervasive one that we're encountering throughout the body. And so that microthrombotic process is worsened by the complement-mediated pathway, which is activated through inflammation, and obviously the inflammatory process we just described, and platelet activation. So the two of these combined contribute further to what we see in terms of thrombosis. And then the inflammatory process at the level of the endothelium, so both endotheliitis, induced inflammation, as well as exposure of the basement membrane as those endothelial cells go on to die, will expose vasoactive substances that result in additional clotting processes that occur within the vasculature. So how does this inflammatory process start? Well, for most patients, the host antiviral campaign is the first line of defense, and these are innate immune cells such as macrophages, natural killer cells, and Th17 cells. These are your frontline defenses that don't really require any kind of memory. We have them for any kind of pathogen that enters the body and immediately goes after the virus in this case. Typically, the type 1 interferons, these are alpha and beta interferons, respond rapidly to eliminate cells that are infected. However, if this host antiviral campaign is ineffective, this can go on repeatedly and unabatedly, recruiting then helper T cells to try and muster a significant B cell response through the antibodies, and also recruits further Th1 mediated pathway, again, in the adaptive immune response. So this is more kind of cells being recruited, all of which are causing these cytokines to be continuously and at high levels secreted, including things like IL-6 and GM-CSF and many other of the cytokines that you hear about. On the right side of this graphic, it's a bit busy, but if you can see on the right side, there's a number of these cytokines like IL-6, IL-1, tumor necrosis factor, and all of their respective cytokine inhibitors and antagonists that are being explored in COVID-19, many of which have been used in other diseases like rheumatoid arthritis and, in fact, like Kawasaki's disease, and are trying to be explored to be repurposed for COVID-19. So as an example, the first one that's probably received the greatest amount of attention is IL-6 antagonist, after things like sarilumab, tocilizumab, etc. These have been traditionally used in treatment for cancer conditions, rheumatoid arthritis, multicentric Castleman's disease, and juvenile idiopathic arthritis, systemic onset, as well as what is the CAR-T therapy that's given for many malignancies, the cytokine release syndrome that's associated with that. And that's probably the closest parallel to COVID-19 we have that we experience on a regular basis, as well as multicentric Castleman's disease as well. Now, some of the downsides of these drugs, there is hypersensitivity. Again, they're mostly humanized monoclonal antibodies, and so there can be hypersensitivity reactions. There's also lipid abnormalities. There are some black box warning related to infection, especially of the respiratory tract, as well as rash and edema, which can be part of that hypersensitivity process. They are given IV or subcutaneously, and they have liver metabolism, so there can be drug-drug interactions. But just as a brief illustration of a few case series, the randomized trials are still pending at this point. These are two out of China, and one from New York by a US group. And these are small single-arm trials, so these are not compared to a placebo or a contemporaneous control arm that would be non-randomized. And so you have to take that into consideration. But the patient breakdown is roughly similar for the first two, about 80% or so male, a little bit older in the first Chinese than the second Chinese study. And then the third study had a little bit greater percentage of women included. Most of these patients were either serious or critical. Some had a small percentage of moderate disease with elevated IL-6 levels. And the doses used were roughly the same across the board. Some individuals only received, for example, in the second study, a single dose, whereas in the first and the last, a fair number of them also received subsequent doses on a weekly basis. And the last study, second and last study had methylprednisolone that was given in addition to antivirals or putative antivirals, and the first study had about half with methylprednisolone. And what you can see is roughly the same number of patients across the board did fairly well. About 20% died in the first, in the third study, and in the second one, which is the one displayed across the bottom from PNAS, 90% of those patients were discharged at the time of publication. And you can see significant declines in C-reactive protein and the temperature, as well as nice respective improvements in FiO2 and oxygen. The next category or next agent to look at are the IL-1 blockade. These include anakinra and canakinumab. These have been traditionally looked at in these sort of more rare syndromes, the periodic fever syndromes, and as well as systemic onset juvenile idiopathic arthritis, astrocyte activating syndrome. These are given either subcutaneously every 26 days, in the example of canakinumab, or they're given on a daily basis, either 4 times or once daily if they're IV or subcutaneous for anakinra. There are some side effects similar to what were described for IL-6 blockade, including elevated lipids and infections. These also have some cytopenias associated with them, as well as headaches. There is a question for long-term use in terms of developing cancer, although this has yet been fully borne out. There is one study here that was looking at anakinra in a group of patients with COVID-19 having hemophagocytic acidic syndrome, so very high elevated levels of ferritin, as you can see here. And by and large, most patients saw resolution in their biomarkers. Here we have C-reactive protein, procalcitonin, ferritin, as well as troponin D-dimer. And most of the patients saw pretty rapid response and improvement in their oxygenation, as well as an H-score, which is kind of a score of measuring hemophagocytic acidic syndrome. And then days to recovery, most patients, again, resolved within the first 5 to 8 days of receiving. To have more randomized, larger sample size studies to know for sure if this is going to be a benefit, but we get at least an early look of no significant adverse effects and maybe some trends towards improvement in biomarkers. This next group, GM-CSF inhibitors, there's a large number of these that have been looked at, and underlining a couple of these, gemcitabine, linzilimab, that are already in trials. There are others now too. These have been primarily looked at for CAR T syndrome, rheumatoid arthritis, but other conditions, CMML, and also JMML looked at for linzilimab and eosinophilic refractory asthma. These are attractive in part because they are fairly upstream of many of the mediators that we're concerned about, like IL-6 and IL-1, by stopping secretion at the level of the myeloid cells when they receive GM-CSF signaling from activated T cells. So that's a really attractive strategy because you don't need to worry about bilateral pathways if you block just one side. And here you're blocking many of them at the same time. There are a few, although not common with all of these. Linzilimab has only rare side effects, usually sort of injection site reactions. But otherwise, some of the other ones include hypertension, and hypersensitivity, as well as alveolar proteinuria with higher doses and shortness of breath similarly. They are given by IV, although the period and frequency for IV administration is fairly reasonable. Limzilumab, for example, can be given every 2 to 4 weeks, typically on most conditions. And in animal models, what they've seen is blockade of GM-CSF has significant reduction in the CAR-T syndrome model. In GM-CSF xenografts that include both human and mouse tissue within the same animal. And you can see across the top line, untreated animals have significant, obviously very few cytokines that are elevated. The middle row, you can see isotype control, a fair amount of cytokines from the CAR-T syndrome. And then the bottom row, you see really very little residual cytokines when you're blocking GM-CSF. And the clinical marker in this case for this model is weight change. And for those animals that were given either not the CAR-T therapy in green or received the GM-CSF blockade for both mouse and human cytokines, the weight remains fairly robust with CAR-T treatment, whereas those that are not given or given the isotype control have significant weight loss. So JAK-STAT inhibitors have also received some attention recently. So this includes baricitinib, ruxolitinib, tofacitinib, others. These have been studied largely for rheumatoid arthritis, myelofibrosis, polycythemia vera. These are attractive for several reasons. Number one, they inhibit, as you can see in the top left figure, multiple cytokines through various pathways in the JAK-STAT signaling cassette. And as you can see on the right, top right side, most cytokines are interrupted in their process of doing the functions that they do, with the exception of tumor necrosis factor IL-17. So you have fairly broad activity across multiple cytokines involved in COVID-19. They're also attractive in part because they're given orally, so you don't have to worry about injection site reactions. Additionally, baricitinib in particular was noted in an in silico, so just an artificial intelligence high throughput screening library of multiple compounds, was found to have even nanomolar level potential effect that was direct on the virus itself. So blocking that virus into cytosis, that engulfing of the virus into the cell, seems to be blocked by baricitinib. And now in vitro models have also borne this out, a recent study that was published just a couple of days ago. So we're pretty excited to see if that has that dual action, both of blocking cytokines as well as stopping viral activity. There are some side effects noted, including infections and thrombosis, usually seen well after the time course of giving the drug for COVID-19, so more than a month. Again, and unclear if those were higher in the treated versus untreated groups in rheumatoid arthritis for baricitinib, for example. And cytopenias as well, and ruxolitinib, because it's metabolized through the cytochrome P450 enzymes, that you do see some drug-drug interactions. So there are a couple of small studies. This is a study of about 12 patients out of Italy. Again, this was, although a single arm, their standard of care were patients receiving lopinavir, ritonavir, just historical to this. So these were consecutively enrolled patients that were given baricitinib after a period of patients receiving, 12 patients receiving lopinavir, ritonavir, and saw significant improvements in ICU admission in time to discharge. And a second study that looked at a smaller number of patients out of Italy, and not only found reductions in, as you can see here, in IL-6 in blue, but also the nasopharyngeal swab PCR detection of virus. You see a fairly rapid decline similarly for the patients during the time of receiving baricitinib. Again, this is uncontrolled, so we don't really know if this is because of the person's own clearance or due to the drug. And currently, the ACT trial, the Adaptive COVID-19 Treatment Trial, phase 2 is including baricitinib in that trial versus placebo with background of remdesivir. So that trial is enrolled so far in 2.5 weeks across the globe, and we're looking forward to see what those results will show in about a month. Finally, tumor necrosis factor blockade. So these include your infliximab and etanercept for commonly used in treatment of rheumatoid arthritis, inflammatory bowel disease, etc. This is a nice, if you're interested in looking at an ongoing database of patients who have inflammatory bowel disease and are receiving a handful of different combinations of DMARDs and immunomodulators, and ended up getting COVID-19 subsequent to that. This is a nice one. You can see the URL, or at least the name of the website at the bottom there. The first cut of these data were published in the Lancet just about a month or so ago. And what you can see here, if you look at the very bottom, are those patients receiving tumor necrosis factor. So out of the 877 patients in this database who got COVID-19, close to 350 or so had received tumor necrosis factor, and you see a fairly low level of ICU admission, ventilator use, and death, at least in comparison to, as an example, those on corticosteroids at a higher level. Again, that isn't a reflection on how steroids would do in this disease, but just certainly the safety, perhaps, of using these agents after getting COVID-19 it gives us some indication. And as you can see as well, which I think is a note for what's going on now, is these agents have been used in Kawasaki disease. So whether or not MISC could be a useful opportunity to treat patients with this drug, then that remains to be seen. But I know it's being used. Dr. Schneider mentioned treatments. Some of the treatments for MISC include some of these tumor necrosis factor blockers. So we'll look to see if that's helpful for that condition as well. There are some downside adverse effects, again, similar ones to the other ones, cytopenias, infections. There are some anaphylactic reactions described and even demyelinating conditions with long-term use, as well as cancers, but again, unlikely to happen with shorter course therapy. So just in summary, I think what's really exciting for us now to think about these agents being able to be helpful in an infectious disease, in particular a viral disease, is really, I think, tremendous. Is sort of a paradigm shift in light of the fact that everything we've thought to date is about antivirals. So I think thinking outside the box with anti-inflammatories, with anticoagulants, et cetera, is really important for us to push the envelope with treating patients. They do at this point appear to reduce fever and cytokine storm, but really we need to know more about the clinical recovery and mortality data. There's unclear if there's any impact on viral control if anti-inflammatories are used, as well as secondary infections, thromboses, and cytopenias. There are a lot more classes than we can talk about in 15 minutes. Many trials are underway, so I encourage you to look into this. And I didn't talk about steroids here. They're not recommended, at least by the Infectious Disease Society of America recommendations, unless within a clinical trial. But we hope to see those to be studied more thoroughly as well. So with that, I will conclude. Lots of people to thank who have helped contribute data and slides, as well, especially to patients and staff who have helped enroll patients in these studies, as well as my family.
Well, thank you very much, Dr. Marconi. That was really an excellent talk, as well as Dr. Schneider's talk, really cutting edge. The purpose of this webinar series is to bring folks the latest information, and this has really been to the point today. So thanks again. We have a number of questions. Please, for those who have not yet sent in your questions, you can chat them into the chat function or the Q&A on either the WebEx or the YouTube or Facebook Live. So we have a number of questions initially for the first speaker, Dr. Schneider. And as a pediatrician, I'll throw out, as you being a pediatrician, I'll throw out the first question that we received, which is any recommendations for summer camps in the New York City area this summer, and whether they should be open or not for children?
I'm just chuckling because that's the natural question to first get here. I am a pediatrician and I am a dad of 2 young kids, and so it's a really important question. I look at this current syndrome of MISC just as another presentation of acute COVID-19 infection. We know kids disproportionately get affected acutely less than the adult population, and this just happens to be one of the presentations. Thankfully, it's still a relatively very rare syndrome. And so to me, and what I've described to many others who've asked, and particularly family members, is that this doesn't change to me the decision making related to opening schools, opening camps over the summer, because we still have to focus on preventing infection is really what it comes down to. And even though thankfully we've seen a decrease in the overall number of acute infections in kids and in adults, it's because of what we've been doing of social distancing and hand hygiene and wearing masks that we've achieved the success. And so we just have to maintain that same vigilance until we have a preventative strategy. You know, I think I saw some recent data that here in New York, there's only about a 19% seroconversion rate. So it's not even close to herd immunity requirements. And so until we have something such as a vaccine, and this is my opinion clearly, that would help lead to a much higher proportion of the population being seropositive, that's really where I think we have to focus the question and focus the attention on the policy making related to schools and camps. So that's my long-winded way of saying I think schools and camps or camps for the summer are probably not going to be open, and I think it's more because we don't have any great ways of yet preventing infection.
Yeah, thank you. Very important question. Next question is, have any of the patients in your series or others required ECMO support?
So that's a really great one. We actually have only had one patient who's required ECMO, but that was for an acute COVID infection, and gratefully she did well in his home. But for the MIS-C patients, no patients have required ECMO. Actually, the vast majority of these kids respond really profoundly well over the first 24 hours. They get, it's really early recognition. They get IVIG and then steroids on board really early. And within 24 hours, most of them are already off of their vasopressors. It's really even a smaller percentage of children who require either second dose or biologics. And so they do respond well. And so I think the focus should be on early identification of these kids and early treatment.
Okay, great. Thank you. Next question is about both the dosing of the IVIG and also the dosing duration of the methylprednisolone. Is the dosing of the IVIG similar to the dosing for Kawasaki's disease? And what is the duration for the methylprednisolone?
Right. So the first one is yes. It's 2 grams per kilo is the standard KD dosing is what we've been using, and the steroid dosing is partially based on the severity of presentation. So we've broken it down into the high risk and low risk populations. So specifically the ICU level kids in shock, if they are on what we consider quote unquote high dose vasoactives, which we intentionally have left slightly gray to allow for some clinical variability or clinical judgment. But the kids who are on, let's say, for example, they'll be on norepi and vasopressin or epinephrine, they'll get a 3-day of 30 milligrams per kilo per day burst. And then they get dropped down to a moderate dose, which would be 2 per kilo Q12. And so, or the moderates will get 2 per kilo Q12, and even the low dose vasoactive, so a little norepi might be 1 per kilo Q12. And they generally stay on that until they are afebrile and starting to show resolution. And then they go on at least it's about a 2-week taper, because that's been shown in the severe KD literature to help to preserve coronary artery and prevent aneurysms.
Okay, and could you also comment on the dosing of aspirin?
Pardon me, sure. The aspirin dose in general is, we do a lower dose, 5 milligrams per kilo per dose per day. We do a maximum of 81 milligrams per dose, partly because they're also generally are getting some type of a dosing of enoxaparin based on their clinical picture and with the hematologist's recommendation.
Okay, thank you. Another question. It mentions there was a recent report, I guess, in Italy speculating that the virus may be potentially less virulent at this point. I don't know if either of you could comment on that? I think you mentioned in your pediatric case series that fewer patients were being admitted to the ICU. Is this a suggestion that the natural course of the disease might have been modified a bit, or otherwise?
Well, I can only speculate. I don't have any good data on the exact serotype or anything of the virus per se. However, we clearly have been seeing a less severe presentation of children now over the last probably couple of weeks. However, I wonder if it's more because that there's a much greater heightened awareness in the community about this syndrome, and children perhaps maybe coming to our attention a little sooner, so they haven't had a chance to progress. That's just speculation. We do know that the virus here on the East Coast of the United States, particularly here in New York, is more similar to what they saw over in Europe and Italy, which is different than what they were seeing in Wuhan or in China, and which is being seen more on the West Coast. But since we've seen the syndrome across the country, there's clearly host response that's kind of contributing as well, I'd imagine.
Okay, great. There was another question about looking at the procalcitonin. Do you think the procalcitonin will prove to be a reliable indicator in the syndrome that seems to be more post-infectious than infectious?
Well, we have seen in general that the majority of these kids have had a significantly elevated procalcitonin. I think the pediatric literature, and definitely my current experience, is I'm getting less and less reliant on a PCT. I think that the negative predictive value is much better. The positive predictive value has been fairly unreliable. It's pretty poor, I think. So, we're looking at it here in our data set of patients, and to try to make more sense of it. I think there's having it elevated, whether it's because there is a true elevation, whether there's AKI that's leading to decreased clearance. It's kind of I really, frankly, clinically, I don't use it much to help make me decide anything.
Okay, great. Thank you for that clarification. And the final question for now, then I'm going to turn it over to Dr. Kazi. Have anti-endothelial cell antibodies or other autoantibody testing been done?
We have not done that here. That would be a very interesting area of research. So.
Yeah, great. Thank you. And Dr. Kazi?
Thanks, Dr. Wax. Thank you, Dr. Schneider. I have a couple of questions for Dr. Marconi, actually. Dr. Marconi, caught one of your last slides, I was monitoring the chat function as well, but I caught it in one of your last slides, something related to inflammatory bowel disease patients that was interesting to me, because I actually saw a patient yesterday at work in the emergency department with Crohn's disease who had a flare-up, and of course was also being tested for COVID with nasal swab, as I was admitting the patient. Discussing the case with gastroenterology, we talked about the pros and cons of starting the steroid therapy, or maybe even the mesalamine. And the gastroenterology fellow who was with me on the phone brought up some risks regarding starting these steroids in COVID-19. Can you elaborate on that in the setting of the material you shared at the end?
Yeah, that's a really great question, Dr. Kazi, and I need to add additional caveats to what that study means, or what that data registry means. So these are patients who are, on a long-standing DMARD or steroids, and so what's actually happening to their immune system after having been on them chronically is very different than what could happen if they're added acutely. And so I think at the very least, what those data tell us is some drugs tend to, and again, this is not a randomized controlled trial, so we don't know if some people are on certain agents for different indications. So there's indication and selection biases built into the observational data, of course. But I think what it at least is showing us is the rates of mortality, hospitalization, and ICU ventilation, et cetera, appear to differ depending on those agents that are used. I feel encouraged to see the tumor necrosis factor blockade and also some of the other ones like IL-12 and IL-23, IL-17 are not shown here. Those appear to have the lowest levels of death and ventilator use, whereas steroids have the higher. But using steroids acutely is not the same as what it would be from long-term use. So it could be worse, it could be better. Typically, from an infectious disease standpoint, when we get more concerned about steroid use is if it's higher doses or longer or both. So we usually talk about 20 milligrams or greater for a month or longer is when we like to prophylax for, say, for example, for pneumocystis carinii using Bactrim. Or if we use massive high levels of steroids in a short period of time, those are also concerning. But shorter courses of lower dose steroids probably have a lower impact than those other settings. If that answers your question.
Yes, and I would like to take it further. So if we have a IBD, inflammatory bowel disease flare-up in our emergency department, and we have not excluded COVID-19 as an infection, because of the swab, the PCR takes time to come back. Would I withhold the prednisone or the steroid course until that results?
Yeah, really good question. I mean, I think in part, if it's going to be low doses, it's probably not as risky for a short period of time than if it were to be higher or longer. Again, that all, as you know, certainly all depends on the individual patient and some of the other risk factors. But this is something that's very intently, in fact, the last several times that we've had a similar conferences like this, people from all over the country, it's a group from New York, who understandably are fairly upset that steroids are not being more closely looked at in trials for treating COVID, because some of these places that have had massive experiences, which I trust very highly when I hear clinicians tell me they're using it for huge numbers of patients, I've had good experience with low-dose steroids in COVID-19 specifically. That's not to your point exactly, but somewhat parallel. We may be running too quickly past steroids because of all the challenges we've had in the past with sepsis and ARDS. But I do think if the right doses and the right amounts are used, we need to consider them as a possibility in a clinical trial setting.
Thank you. And then I know I have a couple of other controversial questions for you, so I apologize ahead of time.
No.
But now that you've listened to Dr. Schneider and during the Coca call, and today we also listened to Dr. Levine from the UK and on the Coca call, what can you extract as lessons from the MISC and the treatment of MISC currently, for example, IVIG, to adults with COVID-19?
Yeah, that's a good question. So thinking about it the other way, I guess I've thought about it in the forward direction more than in the reverse direction. I do think, although there are some parallels, those parallels are becoming smaller and smaller over time in terms of what the presentation, certainly in the pathogenesis of this. And so I think, from a treatment perspective, there still is a delicate balance. I feel much more confident and comfortable giving someone who's absolutely cleared an infection, like most of these children, probably all of them, because the residual virus is probably not active anyhow at that point. And by definition, it's post-infectious and it's immunologically based. Then I do feeling absolutely comfortable in the throes of adult COVID-19 or even adolescent COVID-19 that's during the infectious period. So I think from being able to watch how the immunologic response happens with these children doesn't necessarily give me more confidence or less confidence in what's going on in the adults. I really think these are very distinct. Maybe there's some overlap with individual patients, but there's really very distinct phenomenon that is not entirely informative of one over the other.
Thank you so much. And to conclude, I asked the same question that Dr. West asked Dr. Schneider about the virulence of the virus. This is kind of the question of the hour right now. Have you done this in your experience?
Yeah, that's another great question. Again, we're all seeing, at least on the East Coast, we're seeing declines in our, with a few scattered bumps here and there, and at least in the numbers and the presentations, which can be heavily biased, certainly by what's recent and when things are really busy. It's hard to say if that's virus related. I think the studies are still too nascent to make a decision on that. I do think the syndromes in the presentations are more severe when the epidemic is greater, in part because of dose. And this has been shown in Italy, it's been shown in China, the UK. There are other places where higher levels of exposure, both in clinical settings and otherwise, can result in a greater phenomenon. And that makes sense. The patients that have severe COVID-19 are the ones that actually have detectable virus in the blood, where the reverse is not true. So it wouldn't be unreasonable for us to assume that the quieter the epidemic, the less severe presentations, even just based on that issue alone. But if the virus is playing a role, I would love to know more about that, but I think the data is still not there.
I like the analogy with the dose. Us medical toxicologists, we always say the dose is what makes the poison. So that really resonates well with our medical toxicology community. Thank you again, Marconi. Dr. Wax, the floor is yours.
Okay, I just have three more questions. We have some contact tracers on this webinar today, and one of the questions is about doing contact tracing in minors. Should some of these additional questions that have been brought up with the pediatric inflammatory syndrome be asked now that that sort of clinical information is coming to the surface?
Well, this is James Schneider. These children are not. We don't consider them acutely infectious at this point, but clearly are showing evidence of having had exposure to the virus. So it's an interesting question which I hadn't thought of yet, and I think just on the spot, I think it makes sense to add that into the questionnaire just to get a better sense of the scope of exposure. So these children, I think we try to reinforce, as well as we also try to open up our hospitals and health centers, that these children are not necessarily considered contagious and infectious.
Okay, great, thank you. Two more questions. One is about the inflammation in the fingers and the toes in children. This has also been seen in some adults with the toes. What is the significance of this in terms of the overall presentation and the severity of the condition?
Sure. So what you're referring to is what we tend to call COVID toes. In general, it's a finding that it's an interesting, unique finding that goes along with this syndrome. However, in general, the children are, even the adults that I've seen and I'm aware of, tend to be a much lower acuity level when they have this. And so really, and I can tell you in our emergency department, we've seen many children come in with a fever and perhaps COVID toes, and in general, they get sent home because they're otherwise fairly well and they do just fine.
Okay, great. And the last question, particularly since many of us are toxicologists and use N-acetylcysteine quite a bit, has N-acetylcysteine been explored at all in the treatment of COVID-19 or the post-inflammatory response?
I personally am not aware of it. We have not seen it here. Dr. Marconi, I'll definitely rely on your expertise on this one as well.
Yeah, no, that's a great question. I haven't seen it systematically used. I think we've heard reports of people using it, but nowhere in my direct experience.
Okay, great. Well, I'd like to thank again our speakers for two really outstanding presentations and your patience with answering all these wonderful questions at the end. At this point, next slide, please. We will, again, as mentioned at the outset, be posting this webinar up on our website within 48 hours, should be up by Friday afternoon. Next slide. And we'll continue our weekly webinar series next Wednesday at 3 p.m. Eastern. We have a very interesting presentation on the impact on EMS operations and particularly the approach to cardiac arrest in the setting of COVID-19. We'll have two experts from the EMS community speaking. And we're also going to have an update from the front lines in Brazil. As many of you know, Brazil has become a new epicenter of this pandemic. And we have a colleague down on the front lines in Brazil that will be providing a report. So I hope to see you again next week, Wednesday, June 10th at 3 p.m. Eastern Time. Everyone have a good day. Thank you.